Okay, so dear colleagues, dear attendees, good evening. I will start the first part of this comprehensive imaging meeting about the basic presentation, which is how to approach to OCT layer by layer and how we can analyze the common signs in the OCT in relation to certain retinal diseases. And this presentation will be the basic interactive presentation to the next presentations given by the prestigious speakers. As we know, the OCT was the first non-invasive, non-contact imaging modality that providing cross-sectional image to the macular area, which is exactly similar to the histological section taken through the tissue of the macula. And the main principle of the OCT is similar to the ultrasound. It depends on sending the infrared light that passing through the certain layers of the retina, and each layer will reflect back this and these reflected rays will be picked up by a special detector and will be analyzed and showing to us this image, which actually representing the reflectance of the certain layers of the macula. And once the layer more hyperreflective, it will be black, and once the more hyperreflective, it will be a little bit red. Moderately reflective will be green or yellow, and this is just a false colors. So, okay, so just I want to go through the slides. During the development of the OCT, actually the OCT passes into 3 stages. Starting from the early era, we call it time domain OCT, in which the OCT was a slow and low resolution and very low axial scan, around 400 axial scan per second. And then the second development was the spectral domain OCT, in which the much faster, about 28,000 axial scan per second, and much better resolution. And then we come to the last era of the OCT, which is the swept source OCT, that using the different light source, which is more powerful and able to showing us much deeper layers, which cannot be seen by the previous ultrasound, especially the choroid. So after just a small introductions about the physics of the OCT, we'll come to the how to analyze the OCT images to make a perfect interpretation. So the first step before we start to read the OCT, we need to identify the main structures in the OCT, which are the vitreous, the retina, the choroid. And this is just the scleral border from here, starting the sclera. And sometimes we may look to these empty spaces, the hyperreflective spaces, and we may ask ourselves, is these spaces actually represent a vitreous detachment? Actually, these spaces are normal anatomical spaces, start to be discovered since the emergence of the era of the swept source. And we call them bursa premacularis and the area of Martigiani. They are normal anatomical spaces. And if we look to the vitreous, it actually is attached, it's not detached. And now many investigators, they try to study these spaces in order to predict the time for the PVD. And this is again, they call it bursa premacularis and the area of Martigiani. This is just in order to know if we see these spaces on the OCT are normal anatomical spaces. For the second step, we need to identify the anatomical layers of the OCT in a perfect way. And we will start from the inner to the outer layers, and we try to identify them layer by layer in order to understand later on the signs of the certain diseases. So we start from here. This is the vitreous, and again, this is the bursa premacularis. This is the internal limiting membrane. And hyperreflective layer here is the nerve fiber layer. And if we look, we can see this nerve fiber layer is much thinner on the temporal side rather than on the nasal side. And this is an important thing. So just beneath it, we have the ganglion cell layer. And then coming the inner plexiform layer, inner nuclear layer, outer plexiform layer, and outer nuclear layer. And then we come to the most 2 important layers, is the external limiting membrane, which is this thin hyperreflective line. And just beneath it, we have the photoreceptor layer, or we call it ellipsoid zone. Why these two layers are so important? Because in any retinal disease, if these two layers affected, this is most probably will affect the visual outcome and visual prognosis. And just beneath the photoreceptor layer, we have the retinal pigment epithelial layer, and just beneath it, we have the choroid. Yeah. And we will go through the details in these layers. I found the message every time about the approve and decline. I'll try to decline. Okay, I have a problem with the flipping the slides.
Do it with the mouse, by the way, Dr. Fawwaz. Better, not the keyboard, not the up and down key, the mouse or the mouse pad.
Okay, because I have the mouse. Okay, I have the
laptop. It's a mouse pad. It's better.
Yeah. Not working. Flip the slide, but
try exit full screen or go back to full screen, Mauritania, if you don't mind.
Try to escape the exit the full screen. Still not working.
Okay, I'm going to stop your screen sharing for a second, Doctor, but then
okay, now it's working. Okay. So the third step in the reading the OCT, we need to look to the four main areas. First, the first area is the pre-retinal area, which is the area number 1. And in this area, we need to look to the vitreous abnormalities, because here it's just the vitreous. And the second area is the epiretinal area, which is the area just on the surface of the macula. And the third area, which is the intraretinal area. And the final is the subretinal area. So in the first area, it is the pre-retinal area. What kind of abnormality, the common findings that we can find it? The first abnormality sometimes we find it is the vitreomacular retraction. Usually we see the vitreous detachment on the nasal and temporal side of the macula, and we see this detachment is incomplete, it's just attached to the fovea. And on the OCT, we see the vitreous as the thin, regular, moderately reflective line, which is detached from the nasal and temporal side and attached to the macular area. And this we call the vitreomacular retraction. Sometimes, in some cases, when we look to the vitreous, we found the vitreous is not a hyperreflective, it's not black. It's moderately reflective, or sometimes having some hyperreflective dots. And this is one of the findings that we may see it in patient with vitritis. Also, in a patient with vitreous hemorrhage, we can look here to the vitreous area. We see the vitreous is moderately reflective, and we see the fluid level here. So this is also due to the layering of the blood. So just by looking to the pre-retinal area, which is the area number 1, we can identify some vitreoretinal abnormality and some pathologies in the vitreous, like vitritis or vitreous hemorrhage. Now, the second area is the epiretinal abnormality. And as we mentioned, the epiretinal, it means on the surface. And the common pathology we found it is the epiretinal membrane. Usually we look at the membrane as the hyperreflective line, which is usually stick to the macula in more than 1 point and irregular. And this is completely different from the vitreous, which is thin, regular, smooth line attached to the macula or the fovea at just 1 point. So this is just to differentiate between the vitreous and the epiretinal membrane. Now, we will come to the intraretinal abnormalities, and we'll start, as I told you, layer by layer. In the nerve fiber layer, actually, there is no so much pathology. Just I want to show you this focal area of thickening in the nerve fiber layer, which is usually seen in a patient with cotton wool spots, either due to secondary to hypertensive retinopathy or diabetic retinopathy. Because of the infarction of the nerve fiber layer and the interruption of exoplasmic flow and buildup of exoplasmic flow, we look to the area of the nerve fiber layer, which is now normal. OCT, we see it as a thickened and a little bit hyperreflective. The other abnormalities in a patient, sometimes we find it with a central retinal artery occlusion. Now, we look to the inner retinal layers. We cannot identify the layers as in this patient. And all the layers appears as a one layer hyperreflective one hyperreflective area. So there is no any layer discrimination. And someone may ask why I need OCT in patients with central retinal artery occlusion. Yes, the central retinal artery occlusion usually in most of the cases diagnosed by clinical exam, but sometimes in a patient with a hypopigmented fundus, you may find some difficulties in some cases to diagnose the central retinal artery occlusion. So the OCT may help in these cases. And this sure should be differentiated from other rare case that we start to see it nowadays. It's called paracentral acute middle maculopathy, in which the reflectivity, hyperreflectivity involving the middle layers, not involving ganglion cell layer or the nerve fiber layer, just involving the middle layers. So just I want to pay attention to this condition. We call it paracentral acute middle maculopathy, which is ischemia of the plexus. So now we come to the major changes, which is the cystic changes in the within the retina. Usually we see it on the OCT as a multiple hyporeflective spaces. Usually we call it a cystoid macular edema. And these cystoid macular edema, actually it is the phenomena we see it in many diseases. Camille, again, once the message appeared to me by accept or approve, I got the same problem with flipping the slides. Okay. Want to go through the slides?
Hey, 1 second, Doctor. I'm going to stop your the presentation for just 1 second, if you don't mind. بس ثواني معلش. Okay. Doctor, start sharing one more time. إذا بيطلع لك أي message accept or reject, بس say reject, please.
Okay. So again, we know that the cystoid macular edema, it's a common finding in many retinal diseases. Like
you have to start
Share
sharing.
the screen. You have
Sorry,
to share the screen.
Okay.
Apologies.
Okay.
No.
Okay. And
Yes. Okay.
now it's okay. So as we know, the cystoid macular edema, usually we see it on the OCT as a multiple hyperreflective spaces. That is an indication of the chronicity of the macular edema. And it's one of the common findings. We see it in the patients with diabetic macular edema, patient with a retinal vein occlusion, also in cases of posterior uveitis, and patient also sometimes with hereditary diseases like retinitis pigmentosa. Okay, so Camille, the same problem. I don't know what's the problem. I cannot flip my slides.
طلع لك مسج دكتور هاي المرة ولا without؟
No.
طيب, can you use the right and left arrows بس نجرب؟
I use them, but not working.
This shouldn't happen. 1 second, please. Click on the screen. Click escape, Doctor. 1 second.
Okay.
Choose the next slide. بس مرة نعمل هيك و continue. We'll see if this happens again.
Okay. 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 So the other findings we see it in the as an intraretinal changes is the hard exudate. Usually we look to the hard exudate as a hyperreflective dots. Usually we found it on the OCT with a back scattering, back shadowing, because usually the hard exudates absorbing most of the coming rays, and behind it we see like an empty space. We call it the back scattering or back shadowing. And so we need to pay attention when we look to these hyperreflective dots on the OCT with a back scattering as a hard exudate. Sometimes we look to the edema, like in this case, and we found just on the border of this hyperreflective space, which is the edema, some hyperreflective dots without back scattering. Also, these are always a microaneurysms, which is usually see it on the fundus as a small, a tiny reddish spot. So just we pay attention to these small findings. Now we come to the fourth area, which is the subretinal area. And the subretinal area, just to explain it, is the area between the retinal pigment epithelium and the neurosensory retina. And usually we may find fluid beneath this area. Either will be clear or turbid fluid. And this fluid could be a sign of acute central serous retinopathy, like in this case, or sometimes we may find it in patients with or in some cases like inflammatory diseases like the Harari disease, which we see to the OCT, and we found multifocal neurosensory detachment with a clear subretinal fluid. But sometimes the fluid beneath the neurosensory retina is not clear if it is chronic, and we found it is a turbid containing more fibrin tissue, especially in the cases of the chronic CSR. Now we come to the last layer, which is the retinal pigment epithelium. And if we look to the OCT, this is the retinal pigment epithelium, and this is the retinal pigment epithelial detachment. And we classify the retinal pigment epithelial detachment on the OCT into certain types. The first one is the serous, and we look to the RPE, we see the RPE detaches smooth, and there is a hyperreflective space behind it. And this is we find especially in the CSR. Vascular, the detached RPE irregular, and there is a moderate reflectivity behind it, which indication of the CNV. And in some cases, we may find the blood, like in hemorrhagic RPE detachment, in which there is hyperreflectivity behind it due to the presence of the blood. Now, one of the important pathology we found it in a patient with wet AMD is the CNV. And we need to refresh our memory. We have three types of CNV. The first one, we call it type 1, which is just beneath the retinal pigment epithelium. We look to the OCT here. This is the detached retinal pigment epithelium. And just beneath the RPE, we found like a hyperreflective area. This is represent the CNV. While in type 2, the CNV is just above the retinal pigment epithelium, as we can see here. So this is the retinal pigment epithelium, and this is the CNV. It's just above the retinal pigment epithelium, and the hyperreflective space is due to the edema. And finally, we come to the type 3 CNV. We call it the RAP, and it is just classically we find it like finger-like projection on the dome of the detached retinal pigment epithelium. So just we need to keep in mind, this is just a simple presentations of the CNV on the OCT. But the story is not easy in all the cases. Sometimes, like in this case, or in this case, we may find a very minimal changes indicating the presence of occult CNV. And if we pay attention to this area here, we can look to the RPE detached, and just beneath the RPE, we have another hyperreflective line, which is the Brooks membrane. And there is a space between them. This sign, we called it double layer sign. And the double layer sign, when we found it, it's an indication of a presence of occult CNV. And if we return back to these cases, this is a case actually of occult CNV. And also in this case, there is an occult CNV. And this case of the CSR, there is also an occult CNV. So just we need to pay attention that some minimal changes sometimes need to look at it very carefully. Now we'll come to the first question. This is just a simple question. And if you pay attention to this OCT slide and which layer in this OCT is affected, and we will open the poll for voting. So please vote. Okay. 1, 2, 3, 4, and 5. Okay, so let's share the results. Okay, so most of you, they answered that the affected layer is the ISOS junction, And this is, yes, the ISOS junction is the layer that is affected. Okay, and I will show you, this is the photoreceptor layer here. And if we continue, we can see that there is no photoreceptor here, and there is an increase in the transmission over the affected area. And we call it this area of increased transmission, like the choroidal enhancement. It means the choroid appears more prominent than the other area because there is no photoreceptor there. One of the findings, we see it in a patient with cone dystrophy or other hereditary diseases when we got the loss of the photoreceptor layer. So this is the second question. If you look to this OCT, how you can identify which kind of pathology in this. We'll open the poll for the questions, and please try to vote.
Just to grab everyone's attention, when you vote, please click submit بالright bottom عشان الانسر يتاخد. Thank you.
It's interactive, so we need from all the attendees to share, to vote in order to see, test the knowledge, our knowledge in OCT.
Fawwaz, the poll question is not there. We cannot see it yet.
Okay, but some people, they are voting. So
no, there is the question. What is the pathology in this OCT, Magdi?
The question itself to answer, to choose.
No, it's obvious.
Okay, so to write down.
دكتور موجود بالchat box. أيوة.
Now I can see. Now I can see.
Yeah. Okay. So again, about 19/51, they answered that the lamellar hole. Yes, it is a lamellar hole. So we will go to the explanation of this pathology. So sometimes when we look to the OCT, we found a hyporeflective defect through the tissue of the macula, and we need to know whether this hyporeflective defect is a true macular hole, it's a lamellar hole, or pseudo hole. So just a simple principle. When we look to any defect in the tissue of the macula, just go to the base of this defect and look to the photoreceptor layer. If you didn't find any photoreceptor layer, this is the true macular hole. So if you found a photoreceptor layer, so this is either a lamellar hole or a pseudo hole. So if you found there is a schisis or splitting between the inner and the outer layers of the fovea, this is a lamellar hole. And if you find an epiretinal membrane and steepening in the contour of the fovea, this is called a pseudo hole. So this is just a simple principle. This is a true full thickness macular hole, stage 4. And if you look to the base, there is no any photoreceptor. So this is a true macular hole. And this is again the sample of the lamellar hole. If you look to the base here or here, there's intact photoreceptor layer, and there's a schisis between the inner and the outer layers of the retina. Example of the pseudo hole. There is an epiretinal membrane. Always there is epiretinal membrane, and there is a steepening in the contour of the fovea. Now we will go to the deeper layers, and this deeper layers actually was only accessible after the invention of the web source OCT. What we need to look for in the deep layers, when we say deep layers, we mean the choroid. So one of the very good examples of the using of the OCT in the choroidal disease is the Harari disease. In cases of the posterior uveitis with a choroiditis, like in Harari disease, we got increase in the thickness of the choroid, like in this case. And if you look to the slide below, we can see that the return back of the choroid to the normal thickness after the treatment of the patient. But if you look to the slide, the last slide below, the patient will got the recurrence of the choroiditis again. So the swab source OCT is a very useful tool for the monitoring the patient with the choroiditis, because even with the recurrence, we may look to the surface of the macula and we found there is nothing, but actually there is something going deeply And that's why the ordinary OCT, the spectral domain OCT, is just looking to the head of the iceberg. So this is one of the advantage of the thick choroid, of the choroidal disease. The other thing, the other important thing about looking to the choroid is to differentiate between the diseases in difficult cases. Like in this case, if we look to this OCT, we can find multiple areas of RP detachment, and there is also some subretinal fluid. And we may think that could be an AMD or could be chronic central serous retinopathy. So just by looking to the choroid, we can answer this question. This is a thin choroid. So this is most likely an AMD case, not chronic central serous retinopathy. So that's why now we classify the disease into the thick choroid or thin choroid or even the pachychoroid disease. Now, after the choroid, just I want to give these 2 comments about the sclera. We have 2 findings in the sclera, the staphyloma, which is usually found in patients with high myopia. Usually when we look to the OCT, we find it like the V shape. And the dome-shaped macula, which is the inward invagination of the sclera. And why this sign is so important? Because usually this dome-shaped macula associated with a subretinal fluid. And this subretinal fluid will not resolve with any kind of the injection. And it may be mistaken for a CNV or sometimes even for CSR, but it's just a fluid due to this dome-shaped elevation. And this dome-shaped elevation of the sclera usually caused because of the difference in the scleral thinning between the sclera over the macular area and the neighborhood sclera. So that's just, we want to keep this in our mind. Also, there's some diseases like the choroidal tumors may cause a similar shape. So just we need to keep in our mind 2 important pathologies, the dome-shaped macula and the V-shaped macula. Is in both those 2 cases we can treat in patients with high myopia. We come to the little bit difficult question, even for me. Now, in this image, which is the cystoid macular edema, is it 1 or 2, or either no 1 or 2? I will show you the. Okay, so we'll open for question. Okay, and okay. So which one is the cystoid macular edema? Case number 1, case number 2, both 1 and 2, or none of the above? Okay. So, okay, I will results. Okay, and these are the results. Okay, so actually this question is not easy even for me. Actually the first case was not a cystoid macular edema. It was just a foveal schisis. And the second case was the cystoid macular edema. So sometimes we found the difficulties to differentiate between the 2 cases. And the best thing is to answer this question is to use the other modality of the OCT. We call it in-face OCT. Actually, the in-face OCT, the principle of the in-face is taking the C-shaped cuts, which is not like the ordinary OCT, the vertical cuts, takes the horizontal cuts. And actually, the in-face OCT is very useful in certain diseases. And also in differentiation of the differentiation between similar pathologies, like in the foveal schisis and cystoid macular edema. So in foveal schisis, when we look to the in-face OCT, we see that there is like the bicycle wheel appearance. There's a radiating spikes, hyporeflective spikes with no center. While in cystoid macular edema, there is a tissue in the center with radiating spikes. And this we call the flower pattern. This is called bicycle wheel pattern. So this is one of the important signs we can differentiate. And why I am highlight this point, because sometimes if we consider this is cases as edema, and we keep injecting the patient will not get any improvement. Also, the in-fast OCT will be helpful in some cases, like the diagnosis of PCV, as I will show you in this case. This is just a simple case. It's 62 years old female, presented to me with a drop of vision in the right eye. The best corrected vision was 0.5 in the right eye. The left eye was completely normal. And this is just the OCT, and we can find the two areas of RPE detachment, and there is some subretinal fluid here. So again, what kind of investigation that can help me in the diagnosis? So just when I do the in-fast OCT, I can find that there is multiple polyps here. And also I was lucky even with the OCT angio to see these polyps, which is not always can be seen by the angio, because just 20 to 40% can be seen by the OCT angio due to the low flow within the polyps. So just I want to highlight that the in-pass OCT is useful in some cases, like the PCV. Now, the last thing that I want to show to you that the macular photic injury, and especially the eclipse burn. And usually the eclipse burn in the OCT has a special criteria, a rectangular or the square-shaped defect involving the photoreceptor layer and sometimes also involving the retinal pigment epithelium. So when we see this sign in the OCT, this is definitely one of the signs of the photic injury, the eclipse burn. Also now we found many cases of industrial laser injury that were causing also initially the damage in form of the hyperreflectivity involving the photoreceptor layer, the RPE, and even may involving the external limiting membrane, and later on this damage may convert it into the CNV also. In the last two slides, I want to finish with it, is the future of the OCT. And I think my colleague Pierre Skin, the many meetings, even in the last Retina meeting, he showed to us that this is one of the softwares now working to diagnose the certain retinal diseases. And this software is actually based on two systems. The first one is acting just on segmentation of the retinal layers, and the second one including the data for the certain retinal diseases. And this system of the artificial intelligence was so accurate, and they compare it with 8 expert retina consultants from the Moorfields Eye Hospital, and they found that the error rate in the system was 5.5, while the best consultant in the Moorfield was 6.8. So the system was very accurate and in diagnosis of the certain retinal diseases. And actually, in the future, this system will reduce even the referral rate to the unwanted referral rates to the hospitals. The last slide, just I want to mention it. In 2016, I was lucky, a little bit lucky to attend Zeiss meeting about the OCT, and they launched one of the interesting OCT, which is the built-in OCT that's built within microscope and called OPM system. And actually, this is one of the very useful usage of the OCT in the surgical retina. And the OCT actually, that is built in the intraoperative microscope, providing the surgeons with many options during the vitreomacular surgery, or even the peeling of a retinal membrane, or even in the macular hole surgery. And also, it can also improve the retinal, the outcome of the surgery. And just, I want to show you this less than 1 minute a simple movie for the patient getting the dropped IOL. And just, I want to show you how the screen seen by the surgeon. This is the dropped IOL, and this is the live OCT during the surgery. This is the surgeon trying to remove. And this is exactly what the surgeon seeing during the surgery. And so we will try to pick up the dropped IOL and handle it. And he wants to be sure that gripping the IOL in perfect way to avoid the droppage of the IOL. Yes, and then now clapping so now he handled the dropped IOL, and now to make sure that they grip the IOL from the haptics in a very good way. Okay, so at the end, I wish to thank the Novartis company and for the organization of this meeting. Thank you very much.
Thank you, Dr. Fawwaz, for this comprehensive and well-presented talk. My question, if you hear me well, you hear me?
Yes, yes.
Yes, yeah. May I ask you a question? You think just OCT is enough, or shall we need more imaging modality